Good day and welcome to the Safely Reducing Congregate Care Considerations in the Age of Family First webinar. At this time, I would like to turn the conference over to Chris King. Please go ahead.
Your presenters today are Taffy Compain, a National Foster Care Specialist with the Children's Bureau, Allison Palmer, representing the Children's Bureau Policy Division, Jennifer Marcelli, a licensed and certified social worker and the State Foster Care Agenda Program Area Manager with the Capacity Building Center for States, Dr. Linda Dixon, a Family, Adolescent, and Children's Services Administrator with the Connecticut Department of Children and Families, and Misty McGaugh, a Field Manager for the Therapeutic Foster Care and Shelter Care Programs with the Child Welfare Division of the Oklahoma Department of Human Services. I will now turn it over to Jennifer Marcelli to get started with the agenda for today. Thank you.
Thank you so much, Chris, and thank you everybody for joining us today. Welcome, good morning, good afternoon, depending where you are in the country today. We really appreciate you joining us. I just quickly wanted to go over the agenda for today. After I go through the agenda, I'll let you know our objectives for the webinar. And then you're going to hear from both Taffy and Allison of the Children's Bureau, who will talk about the Children's Bureau vision and talk about the Family First Prevention Services Act provisions as it relates to congregate care. Then you're going to hear from two great presenters who've done really great work in reducing congregate care in their states. You're going to hear from Connecticut and Oklahoma. And then we'll also have a question and answer session at the end. So please feel free during the presentation to type questions into the chat, and we'll hang on to those and we'll have an opportunity at the end for you all to ask those questions of the presenters. And then we'll finish up with available center supports around this topic. So moving into our objectives for today, you all will be able to identify multiple strategies for reducing reliance on congregate care. You'll also be able to increase your awareness of the Family First Prevention Services Act and the Act's provisions related to the reduction of congregate care. You'll also be able to learn from your peers and agencies that have successfully reduced the number of children in group care. And then you'll also receive an overview, as I stated, of the resources that the Capacity Building Center for States has to support you in this area. So with that, I'm going to turn it over to Taffy Compain of the Children's Bureau. Taffy?
Thank you, Jennifer. Good morning, good afternoon. Thank you all for coming on board. My name is Taffy Compain. I'm the National Foster Care Specialist at the Children's Bureau. And I wanted to touch on a couple of things for today's call. First, you all have probably heard, however, I wanted to really reiterate the Children's Bureau vision that we have and that we're working under through our Associate Commissioner, Jerry Milner. And as you see, it's a five-pronged approach, really centered around building strong families. If you've heard him speak recently, you know that he has a lot of passion around really trying to develop more programs, more services, and more funding that's available for prevention services. So he really wants to change the overall focus into preventing children entering foster care. A couple of other areas that center or that have to do with our topic today is prioritizing the importance of families. And within that, really looking at developing foster families in their education, in their skill building, in the services and supports that are provided to them individually and collectively, supporting the foster families so that they're really able to do a much better job, a much more comprehensive and enhanced job of becoming resources to help support the birth families and to be able to keep children out of congregate care as well. We also really want to focus our our interventions on the well-being of children and their parents. So rather than looking at the child, really having a more holistic approach and looking at the family as a whole and really trying to also prevent any additional trauma while they are in foster care. Of course, we also really want to highlight building the capacity of the communities, and we've seen a lot of work that has been done across the nation to really educate the communities on this need and bring them on board, and we want to keep supporting that. As well as we want to have a healthy and stable child welfare workforce. So those are the five key prongs of our Children's Bureau vision, and what you'll see is a lot of our technical assistance and resources that we provide and develop are centered around supporting you in enhancing those particular objectives. Another thing that I also wanted to mention with this in this webinar is that we do have a forecast out. That's for a funding opportunity. The forecast gives you a quick preview of what we plan to ask for in the funding opportunity. The particular funding opportunity that I wanted to give your attention to is one around Quality Improvement Center on the comprehensive development of quality foster families. And so this currently is a forecast that's out on grants.gov. I believe that we'll be giving you the link for that at the end in the resources. You can go to grants.gov and also subscribe if you're interested in this to be able to get future updates. We plan to have the actual forecast, the actual funding opportunity out in March. But this is basically a 5-year grant for $8 million to develop a quality improvement center that would then have 4 to 6 research projects in state and tribal child welfare systems to develop and be able to support high-quality foster homes. And the aim of developing and supporting these high-quality homes is to be able to maintain children out of congregate care and provide them the opportunity to be in family settings where, when you have reunification as a goal, you have a family that is able and has the supports necessary to really then act as a coach, a mentor, and a support to the biological families. So we really look for this Quality Improvement Center to focus on providing foster families the supports that they need, in-home and out-of-home supports that they need, to be able to be high-quality families that can provide enhanced services and maintain children out of congregate care. So clearly that comes from the Families First legislation. Clearly there's going to be a lot of interest in this, so I invite you to subscribe so that you can keep up to date and be able to know when the actual full funding opportunity is released. Unfortunately, I cannot answer questions that go beyond what the forecast currently has. So there is a very summarized, very small amount of information that's out there right now, but that's why we want you to be able to look forward towards that actual funding opportunity and invite you that if you're interested, if your state is interested, to apply for that. So I wanted to let you all know about that, and with that, I'll go ahead and turn it over to Allison Palmer. She'll be speaking with you all more on Family First. And real quick before I turn over to Allison, I did notice that there's a question. I'll make sure that we have you the link either in the participant chat or as part of the resources at the end of the presentation. So you'll definitely have that link. So Allison, please take it away.
Thank you, Taffy. Good afternoon, everyone. So we wanted to just go through some of the provisions related to child care institutions, qualified residential treatment placements, and make sure that we just have a framework for those before we jump into the rest of the call. So as you know, Family First establishes some limitations on 4E foster care payments for children who are placed in child care institutions. All of these provisions are effective on October 1st, 2019, and requests for delayed effective dates have to be submitted to Children's Bureau by September 29th, 2019. So in general, the only way for an agency to claim 4E for a child who's placed in a CCI, child care institution, beyond 14 days is if that child care institution is a QRTP or another specified placement that we'll discuss in just a moment. So 4E agencies can claim for these 14 days, and this is regardless of whether the child has been in previous child care institutions. If a child moves from one child care institution to another, then that 14-day clock starts anew. The requirements don't apply to children who were placed in child care institutions or QRTPs prior to the effective date of the legislation, which is 10/1/2019. And if that child remains continuously in that setting through the effective date, then the requirements don't apply. However, if a child is placed in a different CCI or QRTP after the effective date, then these requirements would apply. So it applies to new placements on or after 10/1/2019 or whatever the state's delayed effective date is. 4E agencies can claim admin costs regardless of whether the facility meets these new requirements that are delineated in the statute. And the delayed effective date cannot exceed 2 years. So these facilities have to meet the definition of a child care institution, which is in the statute. There are three settings that are listed in the Act that allow agencies to claim foster care maintenance payments after 14 days if the setting meets requirements that are laid out. So in terms of parents, pregnant or parenting youth, Children's Bureau isn't defining this, so it's up to the states to define the parameters for this type of child care institution. Same thing with places that are providing supports to sex trafficking victims. Sex trafficking is defined in statute, but states are able to determine what constitutes high-quality residential care, which children are at risk, and the like. So that's up to states to determine. We're not going to issue any further guidance on this. In terms of supervised independent living, this applies to youth who are 18 years old or older, so not for younger children. And here again, the agency has broad discretion to develop a range of placement settings, so it could be, college dorms, shared housing, semi-supervised apartments. The agency has a lot of latitude there. So QRTPs are sort of one of the newest things in the statute, and the placements have to meet really specific assessment, case planning documentation, judicial determinations, and then other ongoing requirements. So we'll talk about those now. So QRTP is defined in the statute, and it has to in order to be defined as a QRTP, it has to have trauma-informed treatment model that's designed to address the needs of children with serious emotional or behavioral disorders. It has to provide discharge planning and family-based aftercare support for at least 6 months. It has to be licensed and accredited in accordance with the requirements. So those are the Commission on Accreditation of Rehabilitation Facilities, Joint Commission on Accreditation of Healthcare Organizations, Council on Accreditation, or any other independent not-for-profit accrediting organization that's approved by the Secretary of HHS. And then finally, it has to have registered or licensed nursing staff or other staff that provide care within the scope of practice and are on-site according to the treatment model and are available 24 hours, 7 days a week. And one thing that we have said is that available 24 hours, 7 days a week does not mean they have to be on-site 24 hours a day. It can mean on-call or available depending on the QRTP's treatment model. So some other requirements around QRTPs. There's a 30-day assessment by a qualified individual, and that individual has to assess a child placed in the QRTP within 30 days of the start of the placement of the QRTP. It can be done prior to the child being placed or during those 30 days, but it has to be completed before the end of that 30-day period. And if it's not completed in the 30-day period, then the agency can't claim for any of the placement, including those first 14 days that they otherwise would get. They can, however, claim admin for the entire period of the child's placement in the facility. A trained clinician must be someone who's not an employee of the 4E agency. They can't be connected to the placement setting either, to the QRTP. But the agency has the ability to request that they waive those requirements and then allow that qualified individual to be a 4E employee, but they have to certify that that employee will maintain objectivity. We have decided not to issue any other guidance at this point about what needs to be in that waiver, but there are instructions on how to do it and how to submit it in the program instruction. And I'll talk about that in a minute. For bullet 2, the court approval that's required within 60 days of the start of each placement in the QRTP. If the court does not approve that placement within 60 days, then the agency has to stop claiming beginning on the 61st day. And then finally, if a child is going to be placed or has been placed in the QRTP for more than 12 consecutive months or 18 non-consecutive months for children who are 13 and over, or for children who are 13 more than 6 consecutive months, then there has to be the approval of the 4E agency. And instead of submitting it directly to HHS, we've issued guidance that those approvals can be maintained or must be maintained in the case file and as part of the case planning, so that they are available for monitoring and available to review at any point, but agencies don't have to send those into HHS. So background checks requirements for adults working in child care institutions, and this is one of the things, again, that's different that states have been really trying to work through. So it amends the 4E plan to require agencies to have procedures for fingerprint-based checks of the NCID, as well as CAN checks of any adult who's working in a child care institution. Agencies are, however, able to use alternate procedures. They have to report them to HHS and describe why those procedures that are delineated in the statute aren't appropriate for that particular agency. And there are directions in the program instruction on how to do that. And then there's another category of placements, and these are licensed residential family-based substance abuse treatment facilities. And this is something that's sort of very different than what we've seen in the law before. These are placements basically where a child is in the facility with his or her parent. Agencies can start claiming for these as of October 1st, 2018. These are not considered child care institutions. They have to be licensed, but they don't have to be licensed by the 4E agency, so another entity within the state can license them. And 4E, the requirements for 4E background checks don't apply to adults working in these facilities. So background checks and all that would be governed by different entities and different statutes. So foster care payments can be made for up to 12 months for an eligible child who's placed with their parent in one of these licensed facilities. The facility has to provide parenting skills training, parent education, individual and family counseling. The treatment must be delivered using a trauma-informed framework. And the child does not have to meet the AFDC requirements that he or she otherwise would have to meet in order to be eligible to receive Title 4E. Note, though, that categorical Medicaid eligibility only applies if that child has been determined AFDC eligible. So even though the child doesn't have to be AFDC eligible to get a 4E payment, in order for that categorical Medicaid to kick in, the child would have had to be determined AFDC eligible. We have said that the agency can partner with other entities to provide the services that are described, but they have to be provided on site. They can't be housed outside of the treatment facility. As I said, admin, agencies can claim admin for the 12 months that the child is in the placement, including for case management, but you can't include admin costs or facility operations costs as part of the foster care maintenance payment. So the admin costs would have to be completely separate. So those are just a very different sort of type of facility, and so we're looking forward to working with states as they start to claim 4E for children who are placed, in such settings. I do want to note that the PowerPoint that you have is sort of very high-level overview of the requirements. It's not inclusive of all the requirements, so I would encourage you not to rely on this solely for policy guidance. And instead, I would suggest that you look at Program Instruction 1807, which it does provide a very detailed explanation of all the requirements for Family First on the 4E side. Also, if you have questions about how to implement or any of the policy issues or what the statute means, you definitely should talk with your regional office, and they can provide guidance, and they work with us in central office as necessary to make sure that we're answering questions consistently across the country. But they are more than happy to help you, with questions large or small. Again, questions about the law, about policy, about implementation. Whatever help you need, we are ready to do that and provide it. So, Jennifer, I think I'm turning it over to you. Is that correct?
Yes, thank you, Allison. I really appreciate you going through all of those. So we wanted to go to a polling question before we get into our presenters. I know we had a lot of questions come up as Allison was talking, and we want to give you an opportunity to ask any other questions that you want the policy department to know about regarding the congregate care provisions of Family First. So if you can take a couple of minutes and type in some answers to this question. So what questions do you have that you want the policy department to know about regarding the congregate care provisions of Family First? And we collected all the ones that you typed in during Allison's presentation, so we'll make sure we have those. The question up here about are emergency shelters considered congregate care? Will there be any further guidance provided on what aftercare means? There's also another question on the screen. We'd like to hear about what barriers you imagine might come up as you work to implement the provisions. So please feel free to type in your answers to that as well. Yes, Sheila, I see your question about are we going to be answering questions on this webinar. Yes, we're going to have a question and answer session at the end with our presenters. All right, we're going to wrap this up in about 1 more minute. And Lynn, we see your question about the PI. We're working to see if we can get that up in the pod by the end of the webinar.
Jennifer, if I can just interrupt for a quick second.
Yes,
one
absolutely.
quick answer. Somebody asked what the definition of a child care institution is, and I'll give you the citation for it, and hopefully this will be helpful. Okay, so it's 472 C2 sort of defines child care institution.
Thank you, Allison. All right, we see a lot of information coming in. So in terms of the questions that you want the policy department to know, we will make sure we get these to Allison to take back. And then in terms of the barriers, our presenters, I'm sure, will talk about some of the barriers they encountered and how they really worked through those. So thank you guys very much for answering those polling questions. And with that, we would like to move on to our first gate presentation. This will be Dr. Linda Dixon from Connecticut.
Good afternoon, everyone. So on my next slide, I want to start by summarizing our system highlights. At any given point in time, the Connecticut Department of Children and Families serves 30,000 children and 12,000 families across our mandated areas of service. This is a snapshot of where we started. So in January 2011, we housed 30% of our 4,900 youth in care within congregate care settings. And today, that's down to 7.7% of the 4,300 youth in care, with only 12 children ages 12 and under in congregate care settings. In January 2011, we had 364 youth in out-of-state treatment settings, and we now have only 7 out-of-state. And up until this past July, we had a consolidated statutory mandate serving youth across child welfare, behavioral health, and juvenile justice. So those numbers reflect all those populations. Since changing in our landscape, we have not seen increases in key indicators that would suggest system implosion. So youth backing up in emergency departments, youth waiting for hospital beds, and critical incidents, we actually did not see an increase. Along the way, we also lost approximately $90 million in our annual budget. The next slide will show you a broad brush of what's been underneath our changes, and I'll touch on these throughout my presentation. Essentially, all of the improvements were supported by changing our relationship with families and communities to one based on partnership, respect, and improved service engagement. Several forces were aligned with that spirit. Most notably, we had new agency leadership that came in early 2011, and that leadership valued families and set a goal of at least 90% of our youth living with families. We've been fortunate enough to keep that leadership in place for a solid 8 years. We also had legislators who were ready to help us support our changes in practice and let us reinvest dollars to help strengthen our families. We embraced a practice model. We use strengthening families, and the heart of that is just family-centered practice, family-centered everything. It was consistent with our efforts in permanency, using data to drive change, components of differential response, considered removal, announced visits. We also focused on fatherhood engagement, and we adopted a racial justice lens. So by this I mean we wanted to honestly and fully recognize and address the fact that persons of color are disproportionately represented at all aspects of the child welfare system nationally and within Connecticut. So we made consistent efforts to talk about racial injustice in our work, to look at our data, and to talk about how racial injustice could impact our decisions. So in this conversation, this helped us elevate our questions from how many youth are in congregate care to who's referred to congregate care and what are their associated outcomes. The next two slides, go to the next one, will tell us how we coordinated our reform. So first we established a blueprint, essentially, and that blueprint told us to cook on multiple burners all at once. Support kinship, support family engagement, develop and enhance foster family recruitment, and our supports for foster families, as well as building up our community-based interventions for families. And we were able to do this because legislators allowed us to reinvest 79 cents of every dollar from our congregate care rightsizing into our community-based supports. We went through a kinship process mapping, and this helped us to uncover our policies and practices that had some barriers to placing with families. We increased our efforts in finding relatives and kin. So we created an internal search and engagement team. They're a great shop, and we trained them in case mining, search and engagement, extreme recruitment, and we expanded our use of Wendy's Wonderful Kids. We also enhanced our foster care services. With more complex kids coming into foster care who would normally be served in congregate care, we needed to enhance the clinical supports and get families access to clinicians on call, psychiatrists and nurses. We also invested a small amount in technical assistance in our foster care recruitment and retention and in permanency. And we chose 357 as a model that we use for permanency. This was for foster care providers, our congregate care providers as well, and our staff. So getting everybody on board on this permanency was very important in the training. We had a very small increase in our foster care rate for our private agencies, specifically to increase child-specific recruitment. In Connecticut, half of our foster care system is run through private agencies and half through us. And for us, we find that child-specific recruitment leads to better matches, more stable placements, and reduces the overall recruitment demand. It's sort of a permission for creativity. We also had targeted service expansions in both evidence-based clinical supports and non-clinical supports. One non-clinical support I would highlight was our caregiver support team, which is our Kin Navigator program. This helps relatives find concrete supports within their own communities. And another non-clinical service to highlight would be care coordination. This is a preventive service. Families do not have to be involved with us to access this service. They get case planning, parent coaching, referrals to family advocacy. And the evidence-based services, we focused on expanding our substance abuse and our intimate partner violence. On the next slide, you'll see that we also examined our out-of-state bed use by cohort, and that helped us to identify our in-state gaps. So through some focused clinical case reviews of the youth out of state, we actually learned that the kids needing 24/7 treatment was really small. So we expanded our community-based options in the state. So one large cohort out of state at that time in 2011 was youth exhibiting problem sexual behaviors. We expanded both our community-based options, and we had in-state providers use their empty beds and retrofit them to serve a very small number of kids. We also started paying very close attention to our surveys of youth exiting foster care and using their feedback to customize our recruitment efforts. So on surveys, what were they saying? They're looking for tech-savvy parents. They're looking for racial and ethnic diversity in our recruitment. and looking for parents who understand needs of LGBTQ youth. We worked very diligently in our 6 regions to engage our families in the past few years, involving family and youth in our planning councils, having meetings within the community where families wanted them to be held. I referenced earlier we focused on engaging dads. Every one of our 6 regions has a fatherhood engagement leadership team. They coordinate events for dads. They try to ensure that dads are invited to case planning meetings. And we just launched a service that links fathers with support groups, resource networks, advocacy, and 24/7 dad training. And we're very hopeful about that service. Through our gap analysis, we also learned that we were missing intensive short-term family work, and we converted about half of our shelter beds to a 14-day family-focused intervention that provides 24/7 nursing. Within a calendar year, we had 80% of those kids get back home to families, and it had a 96% acceptance rate. So that program has been remarkably successful. The longer-term clinical work would then be picked up in the community. Along the way, we pay attention to race and ethnicity in our service outcomes and in our removals. Are we offering support to every family before we remove a child? On the next slide, I talk about self-reflection. We had to take a deep look at ourselves along the way. We learned that our own workforce had to make the same shifts as our providers. So our staff, like our providers, have to take informed risks when they're serving youth outside of a congregate care setting. So the most important thing we started with was an internal policy change to hold ourselves accountable. So the policy change that was the most important was any time a region had over 10% of youth in congregate care, they would need commissioner approval for any other youth to go into congregate care. This really pushed our staff thinking to the next level. We learned that we couldn't just tell our staff not to use resources without giving them support. So to that end, we crafted a special review process. What do we learn when placing youth with families? What are the challenges when there are critical incidents? How can we learn without throwing our staff under the bus? So we now have monthly structured learning forums that involve the highest level of leadership in our regions, and the focus is on substance abuse and families and intimate partner violence. We also implemented a formal supervision model with training from Yale and the Leadership Academy for Middle Managers through NICWE. Along the way, we looked at our state beds. So we operated a couple different state facilities, and we had a lot of empty beds there. When kids were in those beds, they also stayed a very long time. We knew that we couldn't justify these beds staying open with the private beds closing. So we flipped them to a small number where it's PRTF only for intensive treatment with a maximum length of stay of 120 days. We leaned our foster care licensing process to cut down some of the steps to get our families on board and reduce licensing time. We were able to trim that down a little bit. We still have a way to go, but we were able to knock off a couple of weeks in the licensing time. We looked at our voluntary service program, and we just had to make a statement as a department that 24/7 staffed residential care is for mental health treatment and not solely for placement. We had a very small pattern where we noticed some families were coming to us. They had kids already placed in congregate care treatment settings, and they were paying with cash or with their private insurance, and when that funding would run out, they would apply for us. So this was just another opportunity for us to train our screeners in workforce in how to screen for mental health needs. We've made considerable efforts in evaluating our service delivery, so presenting contract data in an RBA format. Our outcomes focus on family work and discharge to families, and everything is cut out by race and ethnicity. We have regional teams right now that use flexible dollars to create out-of-the-box plans for youth. So if we don't have a contract for a particular service, we might pay for something for a short period of time. On the next slide, I'll talk about prevention. So we're the state's mental health authority for children and youth in Connecticut. Kids do not have to be committed to us to access our full array of behavioral health and substance abuse services. So we hold contracts for extended day treatment in outpatient clinics and the alphabet soup of the evidence-based programs, so TFCBT and so on. Non-system families can access these services, non-system involved families. So advertising that was very important to the public and to our sister agencies. Kids did not have to be committed to the Department of Children and Families. They could access those services if they had a behavioral health need. Engaging early childhood experts was very important, so they could work with families before it became known to us. I also referenced earlier differential response, considered removal, and announced visits. So in 2012, very early in that year, we started using differential response. Calls come to our care line and an algorithm is applied. Responses are put into two tracks. One is a traditional investigation track, and lower risk calls are tracked for assessments and referrals. So this was designed to engage parents. In calendar year 2018, we had 42% of our calls handled through assessment and referrals. Considered removal, that's a part of team decision making. We trained our staff to run meetings when the protective services are thinking about removing a youth. So are we assessing a family's strength thoroughly? And if a removal is necessary, a relative and kin considered the first option. So along the same time, we implemented our announced visits versus surprised visits. We found that was less adversarial for families, and it was just resulting in more productive meetings. Something that we've been doing on an ongoing basis is a training with our judicial department, just trying to get judges and attorneys on the same page. We share conferences and hold learning forums on the impact of trauma with young children, reasonable efforts to finalize permanency, the impact of opioids on families, and on racial justice. If you go to the next slide, these are the steps we went through on our actual right-sizing. The department had a history of overbuilding small group homes, and we had to openly acknowledge that. In 2011, we admitted that we built too many small group homes. So we started to look at youth who were in congregate care under the age of 12, and we held expedited permanency team meetings. And it was very important for us to identify champions within each region to run those meetings. What would it take was the focus, how would we get this kid home? Then we moved on to kids ages 12 and up, and we really focused on youth who were in congregate care for longer than 9 months. Soon, and we saw great traction right away with this, and soon utilization in our fully funded programs started to drop, and we were asked by the Office of Policy and Management to start right-sizing. So we looked at utilization over 12 to 18-month period and key variables that we had selected. So we decided to use acceptance of referrals, AWOLs and police calls, treatment hours per week, and discharges to family-based settings. So we picked a couple and just focused on those variables. We shared our population projections with providers every quarter so they could plan their business model. This was very important to them. Once we started taking programs offline, we would assess the system for 3 to 6 months before moving again. So we learned we could only take very few beds off at one time. And we had to balance our timing and look across the state, look at access to services, look at geographical needs. We also noticed that once we started taking programs offline, some providers who weren't fully funded started closing on their own with very short notice due to financial considerations. If you don't keep an eye on that, you can get thrown into a tailspin. We had one day's notice to move 22 children. On the next slide, I'll talk about maximizing our foster care resources. So even though we've doubled our kin placement since 2011, we found we always have to maximize our foster care resources. And how do we do this? We do this best by listening to kids always and always. So trying to find ways to get more resources online is a challenge. We had youth create their own foster care profiles. They filled their own recruitment video. We brought airtime to advertise this recruitment video in local theaters. We've had panels of our teens present at our Racial Justice Forum and in our advocate-sponsored Youth at the Capitol Day. They spoke very poignantly about their foster care experience and the importance of quality matching and recruiting and the importance of interacting with their biological family. As I mentioned before, we launched an intensive foster care program with clinical supports, and that filled a gap for us. And we really worked hard to find foster families who wanted to serve as mentors to biological families for reunification. We invested that small amount in technical assistance for recruitment and retention. I keep bringing this up because it was really moving from more of a classic social work lens to focusing on marketing, messaging, and reaching benchmarks. We had a challenge in our rural areas in Connecticut that's really east of the river. It was very hard to recruit foster families there. We had one agency open and close after a year. They couldn't recruit any families. So we had to really press to have more trainings out there, try to get more recruiters out there on the eastern side of the state, entice providers to move across the river and work out there, and we've tried to increase our substance abuse services for families. I want to highlight two important companion efforts in foster care that we've been working on. The first was a training in LGBTQ awareness, and the second is our Pride campaign. So we worked with an advocacy organization to train our staff, our families, and our foster families on LGBTQ awareness and sensitivity, how to best support our kids in care so they don't bounce across placements. And for our Pride campaign, we were actively recruiting LGBTQ couples who would be great parents for our youth with any sexual orientation in our foster care system. In less than 3 months, we got almost 90 inquiries. On the next slide, I'll mention the challenges. I listed messaging first. We want our providers at the table. I think we learned you don't want to shut down the conversation and you don't want to demoralize staff and providers who do very hard work. Congregate care is extremely hard, taxing, and important work. And if I were to go back, I'd like to stress that it's about making sure that kids get the right dose of treatment for the right length of time. Engaging fathers and relatives. I think early on we were great at finding families, locating them, and we needed ongoing refinements on how to time our discussions about permanency. It felt a little rushed in the beginning, and how to engage families fully. So locating was easier, engaging was harder to learn. Shift in the provider landscape. Some very good providers didn't make it. They didn't make it through this change. Along the way, we had to encourage providers to explore new business models. The fiscal pressure on very good providers through this process can be overwhelming, and they need a lot of support from their trade associations and from their partners. Not on this slide, but caseworker burnout here and secondary trauma to our own staff increased due to the increasing complexity of our cases. That was a direct HR impact on staff recruitment and retention. Again, the coordination of the timing of the change was very important. You just have to have a team of people keeping an eye on what's going on in the state. And the last slide, I'll just talk about the road ahead for us. Connecticut's in the middle of a transition. We have new agency leadership coming. We've lost some legislative allies. We've gained a couple of new faces in the legislators. We'd like to focus on working on some modern touches, search engine optimization, developing an online application and increasing our online training opportunities for foster care, and staying on this kind of modern technology idea. We're also onboarding the electronic niece right now to get used to families more quickly. We're going to press forward on permanency in our workforce development. That's so important to everyone. And we're trying to establish fiscal incentives that promote growth across our private foster care agencies. So that's been our journey so far.
Thank you so much, Dr. Dixon. For folks, again, we'll have a question and answer opportunity at the end. So if you have any questions for Dr. Dixon and Connecticut's work in this area, please feel free to enter those into the participant chat. Before we move on to our next presenter, we wanted to ask another couple of polling questions. So you heard a lot from Dr. Dixon about Connecticut's plan. They had, a lot of different angles that they were hitting to do this work, and so we're just curious for you all, do you and your agency have a strategic plan in place for reducing congregate care? So you could just let us know yes, no, or you don't know. And the other question that we're curious about is, what are some of the key factors that you think will help support the changes that are needed in this area? So there's the family center practice model, data-driven assessment of population's needs, leadership and legislative support. You heard Dr. Disson talk about that. Coordination with the provider community. You also heard her talk about that. And you're not certain. We'll give you a couple of minutes to do that. And again, we will make sure that we have these questions for our presenters at the end. So it's looking like we have about 40-ish% of you that do have a strategic plan and about a little less than 40% that don't. So we're about 50-50 there. In terms of key factors, a lot of you think leadership and legislative support is the most important thing, followed by family-centered practice model. Also coordination with the provider community, yes, which is super critical in this area. All right, we are going to wrap this poll up. Thank you guys for your participation in that. And with that, we're going to get to our next presenter, who is Misty from Oklahoma. So Misty, I'm going to turn it over to you.
Thank you very much. Good afternoon, everyone. This has been a great opportunity for us to share information with everyone who's participating. And I want to first just sort of talk a little bit about and follow suit with Dr. Dixon. So many of the things that she mentioned, Oklahoma has also experienced many of those challenges during our process of reducing congregate care as well. So we'll go ahead and start with my next slide, and I'll tell you a little bit about how Oklahoma has gone about reducing congregate care in a state that has historically always had a very small amount of congregate care to begin with, and talk furthermore about some of the things that we are going to be doing to continue to reduce the use of congregate care. So over the past 5, almost 6 years now, Oklahoma has been under a federal lawsuit that required, and a settlement agreement that required a variety of different things that were associated with congregate care. And I'll explain this a little bit further when I talk about what Oklahoma considers congregate care. But over the last several years, we've had a just general reduction in the number of kids that Oklahoma has in out-of-home placement. And I think the messaging that I want to send about that is whenever you are thinking about right-sizing, looking at your system, is anticipating what that might look like going forward. There was a point in time when Oklahoma had over 12,000 kids in out-of-home care, and today we set generally somewhere just a little over 8,000 kids in care. So really thinking about right-sizing in a variety of different times that your state is experiencing various things. We have the same challenges, budget issues in Oklahoma, in addition to the settlement agreement. So transitioning the total number of kids in out-of-home care has been a huge component of that. So we don't have nearly as many kids in care that need higher levels of care. And then specifically kids in out-of-home placement. So if we go on to the next slide, we'll kind of talk a little bit about what Oklahoma's system looks like and what our existing continuum of care looks like. Oklahoma operates generally between, of that 8,000 kids in care, between 50 and 60% of those kids are in kinship care. Oklahoma has always been very successful at ensuring children are placed with family anytime that we can do that. We also have traditional foster care, which is issued. We have a state-operated system, and we also have contracted foster care providers that provide that traditional level of care. We have a therapeutic foster care level of care currently, and then Oklahoma considers congregate care, if you will, anything like a group home setting, as well as acute and residential care, and then Oklahoma also considers shelter care in the numbers and the information around congregate care. So I'll speak specifically to our reduction in shelter care for this because that's really where Oklahoma started. But just kind of wanted to give you an idea that kinship care makes up around 50 to 60% of that, and at any given time, Oklahoma really has a small percentage overall of those higher levels of care, 10% or less in total of kids that are in congregate care. So if you'll move on to the next slide, we'll talk a little bit about that. Just a couple of other key components. Oklahoma over the last several years has implemented what we refer to as family-centered services, which would really be prevention activities to ensure children stay with their families, if at all possible, before coming into care. We're going to continue to build on that as we move forward with the implementation of Family First, but it was something that Oklahoma had in place and we've been doing for a while. Second piece of that is the Oklahoma Pinnacle Plan, which I briefly talked about, which is the plan that was developed following the settlement agreement. And it's a very strategic plan. It's a comprehensive plan regarding changing the entire system in all types of areas. But there were a couple of specific areas in there that really sort of started the drive towards reducing the small amount of congregate care that we already had. There were some very specific measurements in there around reducing shelter care, and specifically shelter care for children under 13. And then also just the effort of reducing congregate care overall. Kids in Oklahoma, primarily, we don't have a lot of congregate settings outside of shelter care that serve young children. We actually have a requirement through the Pinnacle Plan that requires that kids who end up in congregate care, such as group home level care, must be 13 and older. We have, like I said, very, very few that serve any kids under 13 years old. And this has really just all been a coordinated effort in taking it piece by piece in thinking about how do we start to reduce these higher levels of care that we have for kids. All right, so in 2015, the decision was made by our agency director that we were going to close the 2 state-operated shelters. So in Oklahoma, we had 2 state-operated shelters. Both of them were in metro counties. And we had around 24 what we refer to as youth service shelters, which are private, smaller shelters that are in other parts of the state. Oklahoma geographically is rural as well as the couple of metro areas. And so those were where our shelters were. In 2015, we had approximately 300 children in shelter care. And flash forward now to 2018, we have closed both state-operated shelters and have had a 63% reduction in use of those particular youth service emergency shelters that were there. So it took many of the things that Dr. Dixon talked about. We did very similar things here. We did an overall evaluation of who were the kids using shelter care, why were they using shelter care, how long were they staying in shelter care, and through that process, it gave us a lot of information about who these kids were and where the system gaps were that our system had. And so we were able to gather a lot of information from this particular process. It took us 3 years to do this. We were able to close within, I think, the first 10 months, the first shelter that we worked on, and the second shelter we closed just about 6 months ago. So it did take us some time to do that. But as Dr. Dixon talked about, there was a lot of other factors that had to go into making that decision to do that, and then ensuring that you had the other resources, family-based settings, other levels of care available so that your system didn't sort of go into chaos whenever you closed one set of opportunities for kids. And so we were very strategic about that effort whenever we did that. We staggered the effort. We did one metro area first and then the second metro area after that. And then following the 2 of those, we've been working consistently to reduce the number that are still utilizing those youth service shelters, which is, like I said, on any given day, generally around 75 kids. But it's not very much in the grand scheme of all the kids that we have in care. So if somebody will go to the next slide, I can kind of talk a little bit more about that. So what we learned from that, who the kids were, we identified system gaps that we had around children with intellectual and developmental disabilities was a key group. Obviously, youth that were 13 and older, so the teenage population, and kids who had emotional and behavioral health challenges who had also experienced trauma. Really that kind of co-occurring challenge there was a group that we identified out of this. And so we've taken all of this information during the last few years to think about, with implementation of Families First, what that would look like in our system with kids that we have in group home care. And the group home care in Oklahoma will be the group that's switching over to the QRTP new regulations. But those kids also have many of the needs that we've just talked about, and so our system has been thinking about how do we increase family-based care that can meet the needs of those children of all those levels in a way that is conducive to the supports that they need in a geographic region of the state that a lot of times there aren't a lot of supports available. So one of the things that we are doing with that is our therapeutic foster care program is being bolstered to really be able to accept and serve those kids that otherwise would be served in a congregate setting. So we anticipate in the coming year that there will be some pretty significant changes to that level of care in order to keep kids from being in that higher level of care if they don't absolutely need it. So what we learned, a lot of things like Dr. Dixon said, messaging was important to us, strategic planning and how we decided to do the reduction. All of those things were important. We had a lot of community involvement in the closures of both of the state-operated facilities. We had a lot of challenges around that as well because we had asked the community just half a decade earlier to build us these shelters. And so there was a lot of challenges around messaging, communication, what's next for those buildings, and how can the community be involved in that. And so those were all key components. We had to reduce the stress level of staff and avoid burnout because, we also, just like Dr. Dixon mentioned, we had other facilities at the time who were also no longer operating their congregate care settings and choosing voluntarily to exit out of that. And so we would have those same challenges where we would, in one day be faced with trying to place a handful or more of kids without other options. And so trying to balance those two things while we were trying to close was a challenge, and that happened multiple times over in the process. So knowing that we had to have that as a balance as we went forward. And I think, honestly, that's why it took us a little bit longer than we originally had anticipated to close those two shelters that we operated. So, all right. So, again, with a small amount of kids in congregate care in Oklahoma already, I think this transition will be a lot easier for us than maybe states that happen to have kids, higher numbers of kids in congregate care. But it doesn't mean that the challenges still aren't there around being able to find family-based settings and work through family-based settings that have the supports necessary to meet those needs so that they don't need to be in 24-hour wake or direct care type facilities moving forward. We also are doing a lot of work around, like I said, the prevention side of this. Oklahoma has had that family center services approach. We're looking at some of the other options that we have available to really bolster that front-end work so that kids don't come into the system if at all possible. All right, so partnering with providers really to enhance the placement opportunities and service delivery. I know this is repetitive, but Dr. Dixon said many of this. Having those folks at the table was crucial for us. Having those youth service shelters at the table whenever we were closing the two state-operated shelters. In order to have an emergency option for children, we were going to have to rely on the services that they provided, and historically they had taken children, but we always had the state facilities to fall back on as a last resort. And so having those folks who operated those shelters at the table and ensuring that we had what they needed to be able to do the work that the state-operated shelters were was crucial in that piece of it. Same process went on around building the therapeutic foster care program, having those providers at the table to say, what can you do, what do you want to do, and how can we do this together? So that was very much important. And thinking about all the evidence-based treatment and treatment modalities, trauma-informed care, all of that was crucial and continues to be crucial for us in Oklahoma with the providers at other levels besides the two state-operated shelters we have. So we're having conversations in Oklahoma about Family First. We are thinking about how we take the small population we have and reduce that even more, and really starting to think about specialization. If we're going to have some congregate care, what does that look like, the specialization of that,
because we truly believe that every child deserves to be in a family setting, and with the right supports, kids can be in family settings until they can safely return home or find permanency. So those are the things that we're doing. Oklahoma is still sort of new into the Families First work of it, and so we're still having conversations and kind of figuring out that and working with our providers who are providing that level of congregate care currently and helping them prepare for the transitions. So that's all on that slide if someone will carry on. All right. That pretty much sums up what we have in Oklahoma. It's a real short amount of time. We did this in 2015 to 2018, and so the next couple of years will really be focused on reducing that population predominantly in group home settings and hospital settings as we move into the Family First process.
Great. Thank you so much, Misty, for walking us through all the work you've done in Oklahoma. We're going to move to a final polling question. You heard Misty talk quite a bit about increasing family placements, and so we wanted to hear from you all so you can let us know what you're doing and let each other know what you're doing in terms of strategies for increasing family placements. So if you could feel free to write up on the screen some of your agency strategies for increasing family placements. We'll see what you all come up with. So implementation of treatment foster care, ongoing training and staff development on family finding, that's a great one. Kinship, I like it. I also see something up there around Kinship Navigator. Public-private partnership and collaboration. Lots of really great ideas and strategies. I see up here taking another look at biological family. And they talked about implementing safety organized practice for family engagement. Also a strategy around ongoing, looking at this throughout the life of a case. Lots of answers up here around therapeutic care. Family group decision making. Several up here around family finding, using permanency roundtables. You guys are doing a lot of great things in this area. Targeting foster care recruitment for teens and siblings, so doing targeted recruitment. Peer support for foster parents. Really important to support those foster parents. All right, these are really a lot of great strategies that you all are doing in this area, and I'm sure we'll continue to do. So before we get into the question and answer portion of today's webinar, we just wanted to take you guys through some of the supports that the Capacity Building Center for States has in the area of the safe reduction of congregate care. And so I first wanted to take folks through a publication that we have called Working with Children and Youth with Complex Clinical Needs, Strategies in the Safe Reduction of Congregate Care. And so this guide is pretty comprehensive. In the introduction, it talks about the current population and trends in congregate care, as well as partnerships with private agencies. So you heard our presenters talk about collaboration with the community. You all talked about in this last polling question collaborating with the community, so we talk about that. And then we move into practice strategies for the safe reduction of congregate care. And this includes state and provider examples. And so some of those practice strategies include expanding services to avoid removal and support safe return home. So you heard Misty talk about sort of the front end prevention piece. So we talk about that in this guide. Using early trauma screening and assessments to enable the implementation of tailored mental health services. And again, what we just talked about in the placement in the polling question is around increasing the availability of family-based placement options. Then in the guide, we move to program strategies, and so that also includes state and provider examples And some of those program strategies include working with congregate care providers to change the service array and practices, really looking at developing highly skilled clinical informed workforces to work with the children and youth who are in care, and supporting data collection to inform practices and ensure better outcomes. It also talks about a multidisciplinary committee review process, as well as monitoring facilities to ensure that quality service. And then finally in this guide there's an organizational assessment that can help states and organizations in assessing their current usage of congregate care and identify strengths and challenges in building capacity to serve children and youth with complex clinical needs. And so you'll see on the screen the website for that, so we encourage you to take a look at that. Next, we also have a learning experience called Achieving Placement Stability, and this is really designed to help jurisdictions build system capacity to achieve placement stability. And so there are 7 e-learning modules. It's just an e-learning module learning experience. And it presents a set of scenarios that encourage critical thinking and sharing of best practices. And so those 7 modules focus on, one is youth and foster care, one is around kinship care, the third is adoption, then there's one around siblings, there's another one around LGBTQ youth in foster care. You heard our presenters talk about that. And then there's one for supervising in terms of achieving placement stability, and one for leadership. And on the next slide, we just wanted to highlight this article, Redefining Myself, Finding Normalcy After Congregate Care. And so this is an article that shares a story of a young man who grew up in congregate care and how he moved forward in the world after that. And so it's one of those real world experience stories that is really helpful to read about and hear about. And then finally, in the Capacity Building Center for States, we have a service area called Tailored Services, and through Tailored Services, the center supports individual states and territories, really by engaging and partnering with them to assess capacity building needs and create plans and deliver effective capacity building services. And Tailored Services support states and territories through this process, and it includes a few different steps. Assessment, which is determining the internal and external factors that affect a child welfare system's ability to achieve its goals. Planning, which is developing tailored capacity building plans. And then, of course, support, and that's providing effective services aimed at strengthening the capacities needed for success. And so each region has a liaison that you can reach out to if your state is working with them or not. So if you have any additional questions, feel free to ask us about that. So we just wanted to make sure that we went through the resources and services that the center has to support you guys in this area. And so with that, we wanted to move into the question and answer portion of today. And so I know a lot of you have been posting a lot of questions throughout the webinar, and so we'll make sure we'll get to some of those. So really quick, Jennifer, I see your question about the link for the e-learning modules on placement stability. We'll make sure we get that up for you before the end of the webinar. Oh, great, you found it. All right, so I am going to go ahead and get started with you, Dr. Dixon. So there was a question that came in around what does online licensing mean?
Yeah, by that I meant we are hoping to have families complete their paperwork online, so just less paper and less need to go out to homes to get families online. So just have more application materials online.
Got it. Thank you so much. Misty, I'm going to go to you next. There was a question that came in. Is shelter care in Oklahoma a large facility of a specific short-term foster care for children entering care?
It was. We had the two state-operated shelters that we had. One housed around 40 to 45 kids, and one housed up to 80 children. And then, so those are the two that were like physical buildings that were large, that cared for the large number of kids. And then the other 24 emergency small shelters, many of them are kind of home-like settings, and I don't think any of them are licensed to take any more than 16 kids at any given time. So they're more small, family-like settings.
Great, thank you. Dr. Dixon, I'm going to go back to you. There was a question around what are your fiscal incentive plans for foster parents?
We have to re-examine the rate that our foster parents get. We also have to look at how wraparound dollars are used for our foster families. Right now our families, they seem to have multiple jobs sometimes and struggle in transporting kids to activities. So we really have to look at the rate. We have to look at the wraparound dollars. And for the private agencies, we really have to just make sure we're building in incentives for them to keep recruiting families. So every time they recruit, they might have to hire more staff. We just have to work out the incentives to make sure they keep growing.
Great, thank you. Here's a question for both of you. So Dr. Dixon, I'll have you go first, and then Misty, you can go next. So for Connecticut and Oklahoma, how is your Family First Prevention Services Act planning involving your state Medicaid agency?
Right now we're just having interagency meetings talking about families first. So we've pulled in our Department of Social Services, we've pulled in various agencies right now and just had some preliminary conversations. We have a revenue enhancement team that's looking at all the materials right now.
I would agree with that as well. That's very similar to what we're doing.
Great, thank you. Dr. Dixon, if you lost, quote unquote, good providers of the agencies that survived the change, what did they do right?
I love that question. The providers who were able to survive, they really connected with the communities to find out what the needs were, and they came to us with some plans, and they were assertive in meeting the needs of their communities. They were open to expanding their business model, and quite honestly, they accepted our referrals. Early on in this process, we had a lot of providers who were saying, like, those kids are too high-end, and we're not going to accept them into this service, and send us a different kid. And we just kept making our referrals. These are the kids we had. And the providers who were flexible and who were willing to expand a little bit and challenge themselves, they're still with us today.
Great, thank you so much. We had another question come in for both of you. Would both states share information on their rates or tell us where we can see them?
We absolutely will.
Yep, they're available on the Oklahoma Department of Human Services website, if anybody wants to visit there.
Okay, and another question for both of you to answer. What specific strategies have you used to retain staff through the stress of these changes?
Well, I can speak for Connecticut. We have an internal wellness team that is very active in our department. They talk about, they go out and meet with regional offices in our facilities all the time whenever there's a shift in our landscape. And we offer a lot of support. We offer yoga. We offer anything to help our staff adjust to the increasingly complex work we'll go through the Office of Health and Wellness. It's a very active team.
I can speak in Oklahoma. As I talked about, we were in this settlement agreement and working towards exiting that settlement agreement, and part of that process has been addressing workloads and workload standards. And so we have done a lot in Oklahoma around ensuring that all staff specific to their program areas have reduced caseloads that are conducive to doing good work. But specifically in light of congregate care reduction or reducing shelter care in Oklahoma, we did a lot of multidisciplinary team staffings and sort of walking alongside the staff as we were making this transition so that they didn't feel like they were out there alone. And that was a huge component to us being successful in that effort.
Great, thank you both. That's very helpful to hear about. So just, I want to shift and open the floor to Allison to talk about some of the policy questions that you all had. So Allison?
Thank you. Thank you all for all these questions. They're great questions, and we will be considering them as we work on further guidance. So I just wanted to address a few things really quickly, though. One person asked again about the definition of a child care institution. That, again, is at 472C2 of the Act, and it's defined as a private child care institution or public child care institution that accommodates no more than 25 children. It has to be licensed by the state and includes, whatever licensure for supervised independent living settings. And it doesn't include detention facilities and other restrictive facilities such as that. Another question came in about whether Children's Bureau has model assessment tools. We do not have them, but I believe the Center for States does have 2 or 3 tools that they can provide, but Children's Bureau doesn't have them. And just to be clear, within 30 days of a placement within a QRTP, a qualified individual has to assess the strengths and needs of a child using an age-appropriate, evidence-based, validated, and functional assessment tool. So hopefully that is helpful. Someone asked if children have to be in foster care or removed from their parents, or can they be a candidate for foster care in order for payments to be made to the licensed residential family-based treatment facility. And because the child has to be in the placement and care of the 4E agency, they cannot be a candidate, he or she cannot be a candidate for foster care. Someone else asked whether the 6-child limit in foster family homes, in the definition of foster family homes, only includes children who are in foster care, or is it inclusive of the family's biological and adoptive children? It only applies to up to 6 children in foster care, not the other children. However, there are exceptions to that gives them the state's flexibility. So that number can exceed 6 at the option of the state if it allows a parenting youth in foster care to remain with his or her child, to allow siblings to remain together, to allow a child with an established meaningful relationship with the family to stay with that family, or to allow a family that has special training or special skills to provide care to a child who has a severe disability. So that's a few of the answers. And again, as we continue to put out guidance and consider how to implement Family First, we will be considering all the other questions that you send. Thank you very much for all of them.
Thank you, Allison. We appreciate what you can answer and all the information that you've given. So thank you so much. We have some time for some additional questions. So Dr. Dixon and Misty, I'm going to come back to you. Misty, there's a question that came in that said the Oklahoma presenter mentioned that in their discussion with providers, they asked how they could do this together. What were some of the common requests or resources that the providers asked the state to help them with to make that transition?
Sure. The kids that we were serving in our 2 state-operated shelters were kids with intellectual and developmental disabilities, some kids with co-occurring needs, also kids with obviously high emotional and behavioral health needs, but also kids with medical needs too. So we had kids with diabetes, we had kids in wheelchairs, we had kids that had all types of different things that were served there. And so 2 big requests that our smaller shelters asked us for upon this transition was nursing staff and training. And so we had done a series of trainings with these smaller shelters around trauma-informed care, managing aggressive behavior, a variety of different trainings, medical trainings, prescription medication trainings, and then the nursing staff. And so, because they were not equipped with nursing staff, as the two state-operated shelters were, and so we work to, we have a child welfare nurses team in Oklahoma, and it's a statewide team, and they were able to be deployed to those shelters when needed. And so those were two of the big asks that they had.
Great, thank you. Dr. Dixon, there's a question for you. How did you develop, create, or support the community-based services that you mentioned?
We did a lot of listening forums in the beginning, talking to our staff, talking to kids, talking to families and communities. We also have a youth advisory board here that we talk to at great lengths. We did research. We have an Office of Research and Evaluation, and they helped identify some interventions that we were missing in our array. And we sat down with a lot of legislators, and I keep drumming that point because they allowed us to keep resources and dollars when we were freeing them up from our rightsizing to invest in the community-based supports. So that's really how we were doing it. And we also met with trade associations quite a bit along the way.
Thank you. Here's another question for both of you. How have states dealt with the resistant educational system who do not want to educate a child coming out of congregate care in their local community? And do you have any strategies? I'm not sure if either of you have come up against that.
I'll start with Connecticut if I can. We hit this right away, so when I saw the question, it just jumped right off the screen at me. We hit this early on, and we started with a lot of meetings with the towns and then sending our superintendent over our school district out to meet one-to-one with superintendents and just have a talk about our kids' needs. And after a while, we decided that we had to leverage our commissioner's expertise, and she's a former Supreme Court in the state of Connecticut, a former Supreme Court judge, and she got a team of lawyers, top flight lawyers in the state. She had them trained in educational law, and they do work for us pro bono, so Connecticut Justice Foundation, and they will fight expulsions and suspensions of our kids when they transition from a congregate care setting into a community school. They will fight that expulsion. They will write letters to the school district. So ultimately, that foundation, which again is pro bono, has helped us tremendously. This is a great question.
I'll speak for Oklahoma as well. It's very similar here. We actually have a staff on the child welfare team who is an education specialist, and she has working relationships with all of the different school districts in Oklahoma. And so she is a huge help when navigating those dynamics for our kids coming out of congregate care or kids with disabilities and other needs that some of our school systems are reluctant to or resistant to serving, as well as we have a very similar dynamic around an attorney structure. We have a disability law center here in Oklahoma that's willing to do those same things if needed.
Great, thank you. That was a really great and important question when we think about this work and involving the school. So thank you both for that information and those strategies. All right, so we are coming to time. I know we had several other questions that we didn't get to for Dr. Dixon and Misty, so we'll make sure that we work with them to get some of those answers. And as you heard Allison say, you know, your questions today for policy were very helpful, and they will take those back. I really wanted to first thank Taffy and Allison from the Children's Bureau for being on, as well as Dr. Dixon and Misty for sharing all of their work that they've done in their states in this area. So thank you guys very much for coming on today. As a reminder, in the resources pod, we made sure to put all of the links of the Capacity Building Center resources up there. You'll see those at the top of your screen now. In the resources pod, there's the PowerPoint and the program instruction, and we also have the grants.gov link for the funding opportunity that Taffy talked about. Also, we would love to get your feedback, so there will be an evaluation link coming up shortly, and we really hope that you all will take some time to provide feedback on today's webinar. So we just wanted to say thank you so much for taking time to come on this webinar today, for all your really great questions, and we hope you all have a great day.
We are at the end of our scheduled time, so we will be finishing this webinar shortly. Feel free to contact us using our website, capacity.childwelfare.gov/states. That's capacity.childwelfare.gov/states. You can also contact us by our email address, capacityinfo@icf.com. That's capacityin@icf.com. Or by our phone number, 844-222-0272. Thank you for joining us, and have a great day.